From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
Hello to our listeners from around the world. I'm Dr. Cynthia Armand, Associate Professor of Neurology at the Albert Einstein College of Medicine, Montefiore Medical Center, and JAMA Neurology Web Editor. Joining me today is Dr. Emanuele Cerulli Irelli. Dr. Cerulli Irelli is an Assistant Professor of Neurology at the Department of Human Neurosciences at Sapienza University in Rome, Italy. Today, our topic is in regards to treatment of drug-resistant focal epilepsy in adults. We're speaking to Dr. Cerulli Irelli about the work of him and his colleagues entitled Comparative Effectiveness of Brivaracetam, Cenobamate Lacosamide, and Perampanel in Focal Epilepsy. Dr. Cerulli Irelli, thank you for joining us on this podcast.
Thank you, Dr. Armand. I'm very happy and delighted to be here and to have the opportunity to share the results of our work with you.
The four medications that we are discussing today in this work, when were they introduced into the landscape of treatment for drug-resistant focal epilepsy?
Well, the four medications were introduced in the last 20 years. The first of them was, of course, lacosamide, and then we were introduced Perampanel and Brivaracetam, and more recently, cenobamate came to the scene of anti-seizure medication available for the treatment of epilepsy.
Wonderful. I wanted to start off this conversation with you providing a little bit of a review of the landscape of treatment of focal epilepsy, specifically drug-resistant in adults.
Drug resistance still is a major unmet need, I think, in the treatment of epilepsy in general and especially in focal epilepsy. We know that approximately 1/3 of patients can have unsatisfactory seizure control, and this happens despite the availability of more than 25 anti-seizure medication, both in US but also in European countries. We do not have comparative head-to-head data in the treatment of epilepsy, and our evidence mostly comes from randomized clinical trials which compare anti-seizure medication with placebo. Only few comparative clinical trials were performed in the past, and none of them has been made for newer anti-seizure medication. Real-world studies can help overcome this limitation because they have the opportunity to compare real-world clinical practice when we use different anti-seizure medication. And we came with this idea because in Italy we already had some large retrospective studies investigating newer anti-seizure medication, and we really wanted to harmonize this data and analyze them with a shared framework in order to obtain some comparative effectiveness data that may help clinicians in clinical decision making beyond a trial and error approach without data comparing specifically these drugs.
Right. I think this type of work is very important, the comparative work, because like you just mentioned, we have so many choices and essentially it's a risk-benefit conversation. And we always think about potential side effects, quality of life of our patients. But really, there's always this question of which one should I choose? Am I wasting time with this one? What will be the end result? And I think the randomized clinical trials are great, but real world data comparing these medications is essential.
Yeah, I also agree with you that we tremendously need comparative data in the epilepsy treatment in order to select specific population that can respond better to a specific drug, the drugs working better in other clinical scenarios, the ones that can be better tolerated in frailer patients or in patients where tolerability represents the mainstay of their treatment.
Now, tell us about this study. From what I understand, it's a comparative effectiveness pooled analysis, and you looked at 71 epilepsy centers. This is data from 71 centers. Tell us about how the study was set up.
The study is a pooled analysis of 4 large retrospective chart review studies performed in Italy across 71 epilepsy centers, including primary, secondary, and tertiary epilepsy centers, so different levels of epilepsy clinics. And we, based on these 4 retrospective real-world studies, we harmonized data at an individual patient level in order to obtain a very large data set, including the 4 analyzed drugs in the study. We obtain several clinical variables as baseline confounders, including demographics, baseline treatment burden, baseline disease severity, and etiology. And we used all this data in order to adjust the analysis of effectiveness for the 4 drugs. We included adults with drug-resistant focal epilepsy according to the latest clinical definition by the International League Against Epilepsy, and we excluded all patients with generalized seizure types, developmental and epileptic encephalopathies, or combined focal and generalized epilepsy to have more homogeneous clinical data. And we included only patients with at least 6 months of follow-up in order to obtain long-term effectiveness data that are often missed in randomized clinical trials.
What was the age range of the patients in the pooled analysis?
We only included patients with at least 16-year-olds at the moment of anti-seizure medication initiation, and the median age at prescription in the overall population was 42 years old.
Now, what were your main and secondary outcomes?
Primary outcome was 50% seizure reduction at 6 months follow-up compared with the baseline observation period. We used as secondary outcomes the 12 months 50% seizure reduction and the 6 and 12 months seizure freedom rates, as well as the retention rate at 12 months follow-up. We also noted all side effects reported by patients during follow-up with all analyzed anti-seizure medications.
Before we jump into the results, the rate at which these medicines are prescribed are not equivalent, right? Sometimes we may see one class of medication or one type of medication prescribed more than another. And within this particular study, can you tell us about what that looked like in terms of each of the 4 medications in comparison? Was there one that was prescribed the most or the least? And before we get into our results.
This data cannot be used to infer the prescription rate of different anti-seizure medications because in the pooled analysis we used a pragmatic approach. And for example, one data set was only of patients prescribed with Brivaracetam, and this was the most prescribed anti-seizure medication because this was a very large nationwide data set. Other drugs like Cenobamate were less prescribed, but not because of lower inclination of clinicians to prescribe this drug, but because they came from another study that was an early access program study. So the difference in prescription rates reflect more the studies where the drugs come from than the prescription habits of the clinicians.
Okay, got it. Because sometimes we tend to think about that in terms of our results and what that means. Okay, so take it away. Tell us about what you found in terms of each of these medications and their comparison.
Well, the main result of the study was that Cenobamate resulted to be the most effective anti-seizure medication compared with Brivaracetam, Lacosamide, and Perampanel in terms of primary outcomes and most of the secondary outcomes. Specifically, Cenobamate was linked with significantly higher odds of response in terms of 50% seizure reduction at 6 months. That was more than 5 times higher than Brivaracetam and more than 3 times higher than Perampanel and Lacosamide. Cenobamate also resulted to be more effective in terms of 12 months seizure freedom and in terms of 12 months, 50% seizure reduction compared with the other anti-seizure medication. But this superior effectiveness came with a trade-off, we can say, because patients with Cenobamate reported more frequently side effects compared with other anti-seizure medication. Specifically in this study, almost 60% of patients using Cenobamate reported at least one side effect during follow-up, mostly CNS side effects like somnolence or dizziness, and these rates of side effects were at least doubled compared with other anti-seizure medication that had rates between 15 and 30%.
This is great because we see that cenobamate is performing superiorly. You looked at 12 months seizure frequency reduction from baseline and seizure freedom, as well as retention. How did cenobamate perform in those? Because I would think if someone is saying I'm having side effects, they might not want to stay on it, or they might stay on it because they're doing well.
Despite this higher rate of side effects, the treatment retention was equivalent or superior to other drugs based on this superior effectiveness. But as we mentioned in our discussion of our work, we also need to highlight that patients with cenobamate were included in an early access program within specialized centers where clinicians are more prone to adjust concomitant anti-seizure medications and do their best before withdrawing cenobamate. So it could have seen as a last resort option, and the data for retention could be a little bit biased for this reason. Anyway, despite this important methodological point, the retention was very good despite these side effects, because the clinical practice also suggests that we can adjust concomitant anti-seizure medication to minimize side effects burden, especially when the effectiveness is very good and we want to maintain this profile and this effect in our patients, the patients we follow.
Now we know about cenobamate. Now I'm thinking about which medications were second best performing, and how much less in comparison to cenobamate. And it looks like lacosamide and perampanel were in that running.
Yes, it's not easy to extract this ranking from our analysis, but we can say that at 6 months, there were no difference in terms of seizure freedom between cenobamate and perampanel and lacosamide. At the same time, we know that from our results that lacosamide was equivalent to cenobamate in terms of 12 months retention, and lacosamide was the drugs associated with the lowest rate of side effects during follow-up. But at the same time, we must mention that there could be some residual confoundings in terms of baseline disease severity among patients with Brivaracetam compared with perampanel and lacosamide when considering all baseline clinical variables. We adjust for everything we can measure, but as you know better than me, sometimes there is some residual confounding in retrospective studies, and we cannot exclude that some difference between these drugs were mainly driven by this residual confounding.
Was there additional benefit to using cenobamate since it was the most recent that came out? Because usually sometimes when we're rolling out these medications, there is some additional benefit that comes with the most recent in terms of either side effect or ease of use. Was there something that in between all four of them, one was seen as better at doing than the others in general across providers who are utilizing these meds?
Well, this also reflects our daily clinical practice. Cenobamate, my experience and of my instructor colleagues, really works very well in drug-resistant focal epilepsy, but especially in patients with polytherapy regimen, in drug-resistant patients, it may be associated with a higher rate of side effects and requires a little bit of patience in terms of adjust concomitant medications, especially the ones that might be associated with a higher rate of side effects, and to find the best and effective and tolerable polytherapy for the specific patients we are treating.
That's definitely important to note. Based off of what you found here, what is your next best step in research, and what can you tell our neurologists and providers who are treating adults with drug-resistant focal epilepsy about how to streamline, where to go, where to start?
Well, regarding clinical implications of our work, we can say that this manuscript does not support a single rigid treatment algorithm. On the one hand, of course, our data suggests that cenobamate may offer a higher chance of seizure reduction or seizure freedom in people with drug-resistant epilepsy compared with other analyzed anti-seizure medication. But at the same time, this drug might be burdened by a higher rate of side effects and is also known from its not very favorable pharmacokinetic profile. So, clinicians, based on our data, can discuss with their patients about also their priorities what they are expecting from a specific anti-seizure medication trial. Maybe as initial trial, we can start with something which is more tolerable without too many side effects. And when there is something that we cannot control with more tolerable drugs, we can start with more effective but less tolerable anti-seizure medication. This could be a streamline, but it's not like the solution. We can only provide evidence about what we can expect from each specific anti-seizure medication trial in terms of effectiveness and side effects in a population of patients with drug-resistant epilepsy. Regarding next steps of our study group, we have many ideas about extending the cohort by including other countries. We could be an important step to generalize even more our results and to start identifying in which etiologies, in which specific clinical scenarios a drug can be more effective than another one. In order to have a more personalized and individualized treatment approach, not based only on a trial and error approach, that is definitely something we need to move on in the future.
I'm certainly anticipating this work. Dr. Cerulli Irelli, thank you so much for having this discussion with me today. And I'm looking forward to our listeners diving more deeply into your article.
Thank you very much, Dr. Armand, for having the opportunity of being here. I would like also to thank all the co-authors of the study, especially Dr. Roberti, which co-lead the study with me. And I want to thank very much all of them because without their work, this work would not be possible.
This episode was produced by Shelley Steffens at the JAMA Network. You can find a link to the manuscript in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.